Hi, this conversation is part of the National Forum's broader series examining how we move from cardiometabolic risk screening to meaningful treatment and improved patient outcomes. In other words, how do we strengthen prevention? And I'm very excited today to be joined by Dr. Ada Stewart, who is here to share her insights from both her own practice and from being a national leader of multiple organizations elected by her clinician peers as a national leader. So she's gained a lot of insights into primary care. She is a primary care physician at Cooperative Health, and Dr. Stewart is a former president of the American Academy of Family Physicians. I'm honored and pleased to have you join us today, Dr. Stewart.
Thank you so very much for having me.
Well, you're welcome. I'd like to begin with a quick level set, being if you could tell us a little bit about your background. How did you come to be a family physician? And how did you wind up at Cooperative Health in Columbia, South Carolina?
Awesome. Thank you so much for that question. So I was born and raised in Cleveland, Ohio. And for many years, I practiced there as a pharmacist. So that was my first career, was a career in pharmacy. After losing my mom to what I deemed preventable illness, breast cancer, and my dad to cardiovascular disease, I found that it was very important for me to really look at prevention and how can I stop other families from experiencing the loss that I had. And so I sought out a new career, and my journey led me to family medicine. And that was through looking at a article that we had within our local newspaper, The Plain Dealer, back in those days, that talked about, it interviewed a African American family physician who was also female who expressed how she impacted the community through caring for the mental, physical, as well as spiritual well-being of the population in which she served. And so I thought that that was where I needed to go. And so fast forward, I studied again, trying to take the MCAT, which is the exam to get into medical school. And I was successful in gaining entry. And so upon that time, I knew that I wanted to become a family physician through different rotations. That kind of changed, and actually, it truly amplified the importance of me doing family medicine. I ended up here in South Carolina when I applied to residency looking for places that were warm and nicer than Ohio, which was quite dreary, especially in the winter times. And so I ended up here in Columbia, South Carolina. My plan was to go back to Ohio and serve the community in which I grew up. I was a National Health Service Corps scholar, and with that, you have to have a designated place to practice. And so I ended up signing up for a place here in South Carolina. It was really remarkable because I was able to practice and care for the same individuals where I did residency. And it's been said that many individuals, wherever they do their residency, they end up practicing later on. And I found that was definitely true. I am able to still care for individuals who I delivered as a family medicine resident here in Columbia, South Carolina. And so, after that, I ended up just staying within the community health center in which I started. The first one that I was with was Richland Community Healthcare. We ended up losing our funding, and Eau Claire Cooperative, absorbed the practice. And so I'm still seeing the same patients that I saw previously after starting my practice after residency. And here I am still, over 20 years later, practicing and seeing and caring for the same communities where I started.
Wow. Well, thank you for sharing that background. You've had certainly a very interesting journey. It's interesting to me how many people who do begin practicing in pharmacy end up in medicine or dentistry. That's just interesting, I think, to see. And we appreciate you sharing how you wound up in South Carolina. A little less lake effect snow there than
Yes, sir.
in Cleveland. Yeah. Um, how how did you end up at a federally qualified health center at a community clinic versus a different type of practice setting?
It started with me being a National Health Service Corps scholar. And because of that, you're committing yourself to practice in underserved areas. Of course, I could have left after I fulfilled my scholarship obligation, but I found that that was the community in which I was destined to practice in. And so I remained. And here I am, still there.
Yeah, terrific. And if you could take just a minute or so, I know you are a servant leader in
Yeah.
addition to being a physician, a clinician. Could you tell us just very briefly about some of the ways in which you served the profession and society
Yes.
through medical organizations?
Yes, sir. It's been I say that everyone has a why. And you said it. I feel that I have been a servant leader since the beginning. When I was in medical school, I found that it was important to be the voice for those individuals who may not have a voice, who may not have the opportunity to really express their needs and the things that could make their health much better. I thought about my family and the things that we did not have. I never went to a doctor, never had healthcare and prevention as part of our lives. And so I felt that I needed to be that voice. That led me to being involved within different medical organizations on the state, national, and local levels. And who knew that I would end up being the president of the American Academy of Family Physicians? That was such a huge honor and privilege, of course, being voted upon by my peers, being able to really have that national voice and that national imprint, having a platform to really help the populations and help those who may not have that opportunity to help themselves. In that, I also found that it was important to not only serve my community and my profession, but also serve my country. And so after 9/11, when it was really important for us to, have that opportunity to serve our country, I stepped out there and went ahead and joined the United States Army. And I am still serving. I am currently a colonel within the uh, United States Army Reserve. I have a upcoming drill this weekend where we're going to be out in the field. So I'm still out there doing all the things that I need to do to serve our country and serve our communities and serve the population that really needs us the most, especially as we navigate, a new normal currently within our healthcare systems right now.
Yeah, I'm so glad you just tied that together. I was going to say thank you for your military service. And we hear that routinely all across the country. But I think it's important for us to keep in mind that you're serving every single day
Yes.
in your clinical setting. You're helping people who have fewer advantages than other community members to have opportunities to attain health and to get quality care. So we thank you for your service in all those settings.
Thank you.
Dr. Stewart, uh, how, from your vantage point, both as a local clinical healthcare provider, as well as someone who's seen patients, as well as someone who works at the highest macro level as president of AAFP and board chair of AAFP, in your perspective, your experience, how many people in the general population, how many people get or receive guideline-directed healthcare? And particularly, how many people are receiving guideline-directed preventive care?
Mm. Thank you so much for that question. And when you look at the overall, when we're talking about how many people overall, have a vantage point from my local area and the practice in which I practice, as well as that vantage point from a national level. And sadly, that number is small. Um, when we think about prevention, we think about primary care, and we are really the focus point of being able to provide preventative care. When we look at national outcomes, and our country spends less on primary care, and so our overall outcomes are worse than any of the other developed country. And because of that, the numbers of individuals who really received guideline specific preventative cardiovascular as well as other care is quite small. And it's just it's really hurtful and to me and many of us who are in the primary care space because we are all about prevention. And that decreases the numbers of dollars spent on healthcare. It decreases the number of overall great outcomes because we just are not able to provide that guideline-specific care and guidance to help individuals who need it the most. We're doing
Mhm.
episodic care. We're getting individuals when it's too late. And I always say prevention is preventing, those risks before they become a problem.
Yeah, so let's try to make that an example. And by the way, you phrased it in terms of outcomes. Absolutely legitimate. That's a good way to measure the quality of care that people are receiving. Um, I often think of it as well, and I'll bet you do too, in terms of quality of life.
Yes.
So it's not just patient outcomes that go on a score sheet somewhere, but it's real life impact on people's well-being.
Hmm. As well
Um,
as family and community. Yeah.
yes, yes, that is such an important point. Yes, well-being for the individual, for the family, and for the broader community. Absolutely, absolutely. So have you observed in your career barriers or hurdles that you think help explain why fewer people um, are, why a minority of people are receiving care as recommended by clinical guidelines, why we put fewer resources in the US into prevention than some of our peer countries do.
Yes. So absolutely, absolutely. Some of those barriers are access to care, um, fragmentation of care. Some individuals may receive diagnosis within urgent care settings, ER settings, or when they're hospitalized and then have no follow-up. Not being able to have a primary care clinician, workforce shortages, we see constantly within our society, within our community, within primary care, not being able to afford medications. Not being able to take off work, those social drivers of health, not having transportation. And these are things that I can speak of that I see every day. Not just being able to be adherent to medications because, they may have had a side effect and never followed up, or prior authorizations, oh, the bane of our existence, where, individuals may try to go and get a prescription filled and it's not covered by their insurance. And as a clinician, we may not find out until they come back for their follow-up. And so those are many of the barriers that we see that prevents individuals from being, recognized for their risks and then getting into care, getting into treatment.
And let's try for a moment um, to paint a picture of what that looks like for an individual. Let's say you have an individual with hypertension. Um, Throughout the country, are we know, for example, that hypertension is the second biggest driver of kidney disease, leading to kidney failure, and people facing these horrible choices of do I get kidney dialysis, which is going to have a big impact on my quality of life, or do I die prematurely? I mean, it's a stark, really dark choice. Um, how many people in the US healthcare system who have hypertension are screened promptly or timely for kidney disease? How many people who have early stage kidney disease are diagnosed at that early stage where they can be treated and the progression of their disease can be halted or significantly slowed?
Mm. Yeah, thank you for bringing that up. And I see this every day. Unfortunately, many individuals are screened. They may have a diagnosis of hypertension, but if they do not have a primary care clinician, then they may not get that next step. They may not be evaluated for their kidney disease. We talk about hypertension and we forget, and I tell my patients every day that this is a silent killer. It's a silent disease. So you may not have the symptoms of hypertension. And when you do, it's usually too late. And so we really need to emphasize the importance of having a primary care clinician so that you can follow up with those risk factors, ensuring that they are on the appropriate medication, ensuring that they are evaluated through labs for kidney disease, making sure that we're monitoring their vision and other things that may impact, as well as looking at the addition of other comorbidities, diabetes, checking their blood glucose, as well as their weight. And those are things that primary care really puts emphasis on. And so I don't want to totally blame patients for not being able to follow up, but it's a true systems issue. It's a issue within our community as physicians, as clinicians. Many times our patients we only get a certain amount of time to care for one individual, 15 minutes. And usually that's pretty good for some clinicians, but we have so many things that we have to do within that time. And so we may not have the time to really talk about those risk factors, about getting exercise, about nutrition, about their mental health, about all the other stressors that impact hypertension. And so it's really a problem that we need to address. We need to not only, look at our patients and their barriers, but also the system barriers that causes individuals not to get treatment based on their risks or not to discuss prevention in a more holistic manner.
So, Dr. Stewart, have you found any ways in your practice to overcome some of those barriers?
It's tough. And I can say within my practice, I have the luxury of having behavioral health integration within my practice. We could not continue to afford a nutritionist, but that was very helpful when we had that ability. Community health workers to help our patients be able to get food to help them, see what we can use within the community to help them address their hypertension, whether it's helping with job, helping them find a place to get childcare, helping them to get to the office. We also have within our practice extended hours each week to help individuals who may not have the ability to come during that normal 8 to 5 or 9 to 5. Telehealth has helped, but we have to remember, and I always say this, that everyone, especially here in South Carolina, because we have a lot of rural communities, do not have access to broadband, does not have access to telehealth, does not have access to a smartphone. And so, making sure that we have the abilities to reach out to those individuals who may not have the necessary things that they need to help them to be healthier.
Wow, that's a lot of barriers. I'm glad you're able to take that team-based
Yes,
approach in your clinic, and it's too bad you could not continue to afford to have the nutritionist
yes.
on your staff. Do you have pharmacy on staff?
Yes, I do. And that's another thing. Thank you for reminding me of that, especially as a pharmacist as well. Yeah, we have the opportunity. We have a pharmacy on sta a pharmacy within our four walls. We also have pharmacists that are always available to assist us. And I tell you, without them, we would not have the ability to deal with a lot of prior authorizations that we have problems with. They help guide us. They help our patients to ensure that their care is, as far as medication, therapeutics, to make sure everything is right and ensuring that there's no overlap. Taking care of, individuals who may have medications that they really don't need, or things that were given from another we talk about fragmentation of care given from a specialty clinic, whereas we may be treating them the same way with another medications. And so duplication of medications, they're able to address those issues as well. And thinking about other people that I just had forgotten, community health workers. We now are able to have them within our practice setting. Again, these are things that I have the luxury of having, but there are many of my primary care clinicians who don't have that ability. And so again, having gaps within being able to provide that prevention to the fullest is an issue throughout our country.
What kind of a difference do you think it would make, Dr. Stewart, if everybody everywhere had access to the kind of team-based care that you're able to provide?
Oh my goodness, it would make a huge difference because we've seen, and it's about measuring outcomes, and we've seen improved outcomes once we've had this team-based care and once we incorporated it. And so, what everyone wants to see why it's important to, have individuals have this integrated care, and it's all about outcomes. And we've
Hmm.
seen the improvement in our outcomes, and that's measured in many different ways. HEDIS measures. We also have UDS within our community health centers. And so those really have helped us to make sure that what we're doing is worth the dollars that we're spending to be able to provide this type of care.
And can you see, is there a difference in outcomes if you have pharmacists who are part of the care team versus not?
Oh, yes, yes. And we've seen that. And it's really important to, again, and I'm not just speaking because I'm a pharmacist, but pharmacy is so important. And it's important that we work together as a team to help each other.
Hmm.
Again, we don't have all the time to, go through and see different medications to help with therapeutic levels and ensuring that, the medication that we put a patient on is working well, is decreasing their blood pressure. And so with that, we're able to work with our pharmacy team members to ensure that we're doing the right thing for the right patient at the right time.
Hmm. If, Dr. Stewart, if, well, would it concern you as a physician if when a pharmacist sees a patient who is on blood pressure medication, if they had the ability to ask whether that patient has been screened for kidney disease, and if not, order the test or make the referral so that that person could get tested?
Yes, so that's important. But it's also important because it provides that connection where, one, we may have neglected to do that during a visit, but you have to ensure that you're using the same electronic medical records. Because if they're getting a kidney test done at place A and I'm in place B, and there's no interoperability, then I don't know. And then I'm not able to follow up. And so, again, that's a systems issue that needs to be addressed within our country. Again, that fragmentation of care, not being able to follow up if,
Hmm.
this Dr. A is doing one thing, pharmacist B is doing another, and person C is doing something else, but you have no way of connecting and ensuring that that individual is getting the information to their primary care clinician to ensure that everything is being followed up and being checked on, then we're doing our patients a disservice.
Yeah, all great points. Thank you so much. Do you see, again, in your own experience as a clinician and as someone who's been dealing with policy and systems changes at the national level, um, do you see incentives? Do you see reimbursements and the whole financial ecosystem for healthcare in the US? Do you see that affecting the quality of care that patients receive, that you are able to deliver? And if you had a magic wand, what would you change?
Yes. So definitely finances. And it's medicine has really changed. It's all about now with looking at money. And of course that is important, but remember our country spends more on healthcare, but we have the worst outcomes. And so as we think about, where should we put more of the dollars, that should be put within primary care. And it's important to realize that when we are prescribing medications for individuals, we see that insurers are looking at cost versus whether this medication works best. So we have to deal with prior authorizations and other things that come to decrease our ability to really get individuals on the right medications, to making sure that they're getting the right testing. As we are now faced with a decrease in Medicaid fundings, I'm worried because of costs that we're going to end up having more individuals who will be uninsured, more individuals who may not be able to afford their medication and their treatment and their access to care. And so when that happens, individuals don't get care. And so we end up seeing folks when the condition is at its worst. And
Yeah,
hopefully it's not after someone has passed away or end up on dialysis. We
right.
want to prevent that prior to. So if I had a magic wand, I would take cost as much out of the picture and put that patient in the picture and at the center of all of this first, because that is the most important. And with that, putting prevention as well as putting more of an investment within primary care so we can take care of individuals before conditions get worse.
Yeah. So prevention-based, patient-centered care.
You
Uh,
said it. Thank you.
yeah. Um, you made the comment a couple of times about prior authorizations, and we talked earlier about people not receiving, so many people who do not receive guideline-directed care. So I want to ask, aren't prior authorization requirements sometimes intended to ensure that people are receiving guideline-directed treatment?
So that is what we would call the reason that insurers are pushing for prior authorizations. On the front lines, it creates a huge barrier. And we, as the clinicians, as well as when I was president of the American Academy of Family Physicians, and even now, prior authorizations are part of the administrative burden that most physicians, and I would say the majority of physicians say that is the reason for burnout and reason why we are seeing a decrease in our workforce, as well as individuals getting out of practicing. And so the I would say that the emphasis is to, ensure that they're receiving guideline-directed care, but in truth, that is not what we see. When we see an individual who, and I can say for instance, I had a patient just the other day who I had been who's been maintained on a certain blood pressure medication for over 4 years. Because of their new insurer, who decided that that's not a medication that they covered, that individual was no longer able to access the medication that they have been maintained on for a number of years. And why
And I
should
just
that
want to
be
be
a
clear,
problem?
pardon the interruption, Dr. Stewart, but just to be clear, this was a case where the medication was no longer on the formulary. There wasn't a clinically indicated need to change. Is that correct?
Exactly. Exactly. Yes, sir. And so then, we almost had to start from scratch again. And the patient was, of course, very upset, wondering why, we have to, try another medicine when, medicine A was working. And then that ended up with a trust issue as far as clinician to patient was concerned. Why all of a sudden are you, clinician, changing my medicine when uh, actually it was the insurance company that was requiring us to change the medication. So it's a problem. It's something that needs to be addressed. And I think that is something that as as part of organized medicine, we all see that this is a problem, and we
Hmm.
need to find solutions to alleviate the burden of prior authorizations as we practice and care for the patients that we care for daily.
All right. Thank you for making that clear for us and helping us understand the effect that the prior authorization requirements and the way that they're administered affect real life clinical practice and patients. One word I didn't hear in there, and uh, I'm not looking for this word particularly, but the concept. Um, does the kind of forced change that non-clinical change, does that affect medication adherence? Does that affect how a person is able to stay on a treatment that's working effectively for them?
Oh, yes, for sure. And, when individuals have a delay in getting their medication while we're trying to get a prior authorization, then that's a delay in treatment. That's a delay in individuals being able to stay on medications that's been working and that has been doing well for them. And when you put patients, have to go through some hoops and go through barriers, then that decreases their willingness to stay on medications. And it's something that we've gained that individual's trust, and what this does is it kind of makes them think back, uh, should I really trust this process? Is this, if this needs to be changed, was I on the correct medication in the first place?
Hmm.
And so those are things that, we don't think enough about, but they really impact the opportunities for individuals to stay adherent and compliant with medication regimens, and making sure that we are able to have that shared decision making with that individual that we are caring for.
Well, Ada, you just provided a perfect segue into my next question, which is I'm wondering from your vantage point, does shared decision making make an impact one
Yes.
way or the other on the success that a patient has in managing their cardiovascular risk factors?
Yes, definitely. When we are able to have that individual, participate and be part of our plan, it really helps with them feeling empowered and feeling that they have a part to play in their overall health. And so definitely it makes a huge difference. And it's how we actually are able to decrease risks in our individuals, asking them, is this medication something that you are willing to stay on? Sharing with them, potential side effects, sharing with them potential costs, making sure that they know that, in addition to the medication, there are some things that they can do to help decrease their cardiovascular risk, exercise, weight loss, and just talking with them in a open-ended, non-judgmental way, helping them to be part of the process really helps them to feel engaged and empowered and just excited about being part of their health. And so that way they are adherent. That way it helps us to ensure that we're doing things together and not in silos. And it's so important that we're able to provide that shared decision making with our patients, and their overall health ends up being in uh, just life ends up being better because they feel that they're part of the process and not just being left out of the
Yeah.
process.
So I'm hearing you, I think, say that shared decision making results in greater patient engagement. And then it also leads to patient empowerment so that they are, in fact, more capable, more empowered to take an active role in managing their conditions and their risk factors. Is that an
Yes,
accurate paraphrase?
yes.
All right. All right. What role does the EHR have, electronic health record, have in a path to the future? Are you using decision prompts or any decision triggers that are built in? Is artificial intelligence and the EHR able to help you flag priorities for discussion and perhaps testing or treatment with individual patients?
Yes, definitely. So EHRs are playing a huge role. We're able to flag when a certain preventative measure is due. Um, but again, recognizing that we do not have true interoperability of all EHRs throughout our country, and even throughout, like locally, within our local communities. Different healthcare systems have different EHRs, and unless you are in that system network, then you miss out. And so you end up having fragmentation of care. So there are some barriers that EHRs have. And also some benefits. So yes, definitely it can help you to recognize when certain screening methods are due, when certain prevention modalities are needed. And so it helps, but we can't be totally dependent upon those systems because there are some gaps, especially because we have different systems within different communities, within different areas.
Yeah, so you said it very early in our conversation, interoperability
Yes.
is very important, and I appreciate your underscoring that right here. Um, what what are you most hopeful about right now? You've identified changes that would be helpful. You've identified barriers to enabling everyone everywhere to attain optimal health. What makes you hopeful that we either are moving in the right direction on some things, or that perhaps by taking better advantage of innovations, we can help more people everywhere to benefit from the system?
Yeah, so I'm really hopeful right now that patients are now becoming more engaged and more empowered to take care of their health. We have the opportunity for individuals to monitor their blood pressure, to monitor their glucose, to monitor their weights. And that is something that I am really hopeful that can continue to improve the outcomes that we are currently seeing with individuals not really being properly screened as well as treated for many of the health conditions. So social media also plays a huge part, and I think it's important, and I'm hopeful that individuals can use platforms like this as well, is to become more empowered and more engaged. I'm also hopeful that we see the importance of primary care and really looking towards spending more on primary care, which is the sole basis of prevention. And so those are things that I can think right off the top of my head that I am truly hopeful for, and hopeful that we can be able to accomplish those goals so that we can improve the health for all. And really decrease cardiovascular risk and ensure that individuals are healthy and that they don't end up with um, bad outcomes and just improving the health of our communities are so important.
Thank you. Thank you, Dr. Stewart. Final question. You referred earlier to people sometimes getting screened, but then not treated effectively, or a result of their screening is not successful management of a condition that is detected. What's your prescription? You write prescriptions for patients every day. What's your prescription to policymakers or to health system decision makers to enable us to close that gap and ensure that when conditions or risk factors are diagnosed or detected, that people then are able to successfully manage them and mitigate the risk?
Yes. My prescription is everyone needs a primary care clinician.
All right. That is pithy. I love it. Well, Colonel Ada Stewart, Dr. Ada Stewart, we're very grateful to you for your leadership, for your service to our country, to the profession, to public health, to making the world better in concert with all of us who are hearing you today. And we thank you so much for spending some of your time with us and your insights and ideas.
Yes. Thank you so much. And thank you for this opportunity.
Dr. Stewart, you mentioned earlier in our conversation that your clinic had to stop offering the services of a nutritionist, even though having the nutritionist made a positive difference in the outcomes that you were attaining for your patients, or helping them to attain. And we know that all clinics that are serving underserved patients are under tremendous financial stress. Um, how does the 340B program affect your ability to provide the kind of quality care that you would like to, and that would enable your patients to have the opportunities to attain optimal cardiometabolic health?
Yes. Thank you so much for that question. And it's something that personally within my practice are seeing now. We do have a 340B pharmacy program here. And with many of the changes, we see that individuals are not able to afford the medications that they would need and that they do need. It has been something that over the years, we've been able to use the dollars that we were able to get by using the 340B pricing to be able to care for the patients that we are currently serving. And with those cuts and with those potential damages to that program, we're going to see individuals not be able to afford medications, for us not to be able to afford certain services that we are able to and should be able to provide to improve the health of our patients. So definitely, we really need to encourage continuation of this program. It helps the individuals who are just can't afford medications. And we are seeing if you can't afford a medication, then you don't get it.
You're not
You
going to
end
take it.
up, you're not going to take it, and it worsens potential outcomes and worsens the health of our patients and again, ultimately their families and communities.
Right. So you're talking about the out-of-pocket cost for a patient to a
Yes.
medication they need. Are there other impacts as well? Are there other ways that cooperative health uses 340B dollars? Does your ability to have, say, the community health worker and the social worker on staff providing support to patients, does 340B enter into that at all?
So that I cannot truly comment on. I don't know exactly where all those dollars are funneled,
Uh-huh.
but I'm sure that that does play a huge part of us being able to have the integration of services and to better care for our patients.
Okay. Okay. Thank you. And I'm sure you all at Cooperative Health face the phenomenon that other clinics do, where you have some enterprises that are trying to contract pharmacies and so forth that are trying to siphon off as much of the pharmacy business, the 340B business as you can. So then your pharmacy and cooperative health in turn are realizing fewer of the dollars from 340B. Does that affect your ability to provide optimal care to your patients? And if so, how?
Yeah, definitely. So, and I'm just thinking of potential examples. I have a number of patients who are on medications and they are told that they have to use a specialty pharmacy and not the pharmacy within our building and not the pharmacy that they have been used to based on the insurance. What happens
Who
is
tells them that?
the insurer. And
Okay,
when we go to try to fill the medication at our pharmacy, we are told that this medication and this prescription has to be filled at a specialty pharmacy. So that decreases the ability for us to, one, fill that prescription. Two, when patients have to go to different places for care, remember if they're getting all their care in one place, that helps with adherence, that helps with them staying into care.
sure,
And when
the
they
whole
have to
continuity
go
of care.
I'm sorry?
The whole continuity of care.
Exactly, exactly. So that creates, again, another barrier that impacts our patients, impacts their outcomes. So,
Mhm.
truly something that I'm seeing and I'm seeing more of lately.
So if you were able to make changes to the program, to the rules, what kinds of changes do you think would benefit both the patients you're seeing and society?
Yes, being able to get their prescriptions where they want to get them at. And if that's within our system where, they come, they see Dr. Stewart, they're able to go to our pharmacy, which is in our same building, go there, get their medication, and move on with their lives. And also, I'm able to keep better track of their medication fills. Our pharmacy, again, this is integration and team-based care. They keep us apprised of how well the individuals are doing as far as picking up their medication. Those are things that help, again, with outcomes. And so without that, again, individuals will be harmed.
And that ties back to what you said earlier is a barrier to providing the best care, the best health opportunities for everybody everywhere, and that's fragmentation.
Yes, yes.
All right. Dr. Ada Stewart, thank you again so much for your time this morning. Thank you for having the conversation. I think this will be really valuable for viewers and listeners.
Thank you. Thank you so much for this opportunity.
Oh my gosh, thank you. It was a pleasure and an honor.
Thank you.